with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. It is now my pleasure to introduce today's presenters. Mark Graban is a consultant, author, keynote speaker, and blogger in the world of Lean. Mark is also the Vice President of Customer Success for the technology company KNexus. He is the author of the book Lean Hospitals, Improving Quality, Patient Safety, and Employee Engagement, which was selected for a 2009 Shingo Research and Professional Publication Award and is being translated into 7 languages. Since August 2005, Mark has worked exclusively in healthcare. From 2005 to 2009, Mark was a senior consultant with Value Metric Services, a division of Johnson & Johnson. From June 2009 to June 2011, Mark was a senior fellow with the Lean Enterprise Institute, a non-for-profit educational organization that is a leading voice in the Lean world. Mark earned a BS in Industrial Engineering from the Northwestern University, as well as an MS in Mechanical Engineering and an MBA from the MIT Sloan Leaders for Global Operations program. Greg Gordon is the Senior Director, Strategic Consulting at Kronos Incorporated. Greg, a mechanical engineer by training, has led a successful career spanning 25 years focused on unlocking the full potential of the workforce. Currently, his practice focuses on using business intelligence technology to improve data-driven decision-making. Passionate about workforce management and the role of labor in achieving operational excellence, Gordon authored the book Lean Labor, which describes the approach to implementing the Lean philosophy when improving labor effectiveness. Gordon has a degree in mechanical engineering from Stevens Institute of Technology and a master's in business administration from Boston University. It is now my pleasure to turn the floor over to Mark Graban to begin today's presentation.
Emma, thank you for having me here, and it's a real pleasure to be with you and Greg today to talk about I think it's a really exciting topic, and that is the topic of how do we use Lean as a methodology and a management system and a culture to improve healthcare delivery, for the patients, to improve safety and quality, and all of the other things that are important in healthcare, but to also create a better working environment for healthcare professionals, employees, and staff. And these ideas go hand in hand. We can transform healthcare, and a lot of organizations are really truly doing this, by collaborating with and tapping into their greatest asset, and those are the employees and the healthcare professionals. It runs the risk of being a bit of a cliche to say, well, employees are our most important asset. And they're not technically an asset from an accounting standpoint or anything. But the lesson I learned even early in my career in the auto industry was that lots of companies can have the same equipment, the same technology. We can hire the same people from the same schools and educational backgrounds. But the only thing that can really differentiate us as an organization are our people and our culture. That was true in manufacturing, and I think that's very, very true in healthcare. So when we talk about Lean in organizations, unfortunately, the word or even just the idea that, we've got another new approach can lead to maybe some negative or indifferent reactions as pictured here. Well, why Lean? Or, oh gosh, another program. And I think we need to make sure we engage people, not just by saying, well, we want to quote unquote do Lean or we want to get Lean. But the thing that really engages people is solving problems that matter, and not thinking about as sometimes people reach out to me, they'll ask, hey, we want to get Lean, we want to implement Lean, if that's even the right way of saying it. What tools should we start with? I'm like, well, wait a minute, time out. I think we need to do like John Shook from the Lean Enterprise Institute would ask, and this is a good Lean habit to ask, What problem are we trying to solve? When we start with that, with problems that matter, we can engage people to get their ideas, to help them research and understand why these problems are occurring. So we connect, as you see John at a whiteboard here. We talk about value to the patient. We talk about purpose. What are we trying to accomplish as an organization? And we can combine process improvement with a focus on developing our people, developing their capabilities and problem solving skills and creativity. And that surrounds a management system that includes certain types of leadership behaviors that we would describe as lean management. So why does lean matter in healthcare? What types of problems are we trying to solve? I think arguably safety and quality are the most important things, challenges or maybe even a crisis in different countries, not just in the United States. We can start, if you look at this diagram, with the idea of employee engagement. We listen to people, we let them participate in improvement. We are being supportive as leaders and as an organization. I think employee engagement is not just a nice thing to do. I think it's the right way to lead, but because it's good for the organization, because it's good for the patients. Employee engagement correlates to, and I would believe causation, to better patient satisfaction and better quality and outcomes. These things can flow through and lead to better financial results. It might flow through and lead to better, higher patient volume. And these are all interconnected, but a lot of it starts with the employee. And if you believe the perspective that's shared by many that say, if you take care of the staff, they can take care of the patients. I think that's a very powerful and important message. Increasing employee engagement can go directly to the bottom line because we reduce turnover, we reduce the cost of hiring new employees, and then it flows through in many different ways, through quality, patient satisfaction, et cetera. In the lean philosophy, we certainly are concerned about the long-term financial results, not just this quarter, not just this year, but we view cost and financial results as being the end result of doing everything else well. And I think that's an important lean perspective. So we focus on people. And in a way, I'm happy to see there's been a growing number of articles and publications and books that talk about, in some prominent way, this idea of the people side of lean. And this is a great message, but part of me steps back and says, well, isn't it all the people side of lean? When we talk about culture and leadership, problem-solving skills, lean is not about technology and technical tricks or methods. It really comes down to the way we lead, the way we operate on a daily basis. That's really about people. But at the same time, I would probably more readily accept that it's all the people side of lean than I would accept the idea that I hear sometimes that, well, lean is just a toolbox. And we have these different process improvement tools, and we can choose from those tools, or lean as a tool versus Six Sigma as a tool. And I think this is incorrect, and I think it diminishes the power and the potential of lean. To label lean as either just a collection of tools or to label lean only as a process improvement methodology. I think we lose the real potential to transform healthcare if we just cherry pick a tool or two that sounds appealing. Now, it might be good if that tool is solving a problem, but I think sometimes we need to challenge ourselves to look more holistically. So I love the analogy of an iceberg. And when you talk about, let's say, visiting a great lean organization in healthcare or in manufacturing, here where I live in San Antonio, we have a Toyota truck plant. And I often volunteer to take healthcare students, MHA students, to go visit the plant. And part of what we try to be careful about is when we go and see with our own eyes, we see the part of the iceberg that's above the water. We might see artifacts and lean methods in place. We might see value stream maps on the wall at a hospital. We might see A3 problem solving sheets. We might see 5S practices and Kanban systems. But what we don't see is the part of the water, the iceberg that's below the surface of the water. This is the largest, bigger proportion of the iceberg is unseen. And the same is true in a lean hospital or a lean factory. What are the things that really matter? We could copy tools. The right tool in the wrong culture might not be effective, or it might actually be counterproductive if we're not also trying to understand. And this takes discussion and deep study and reflection to understand things like the management system and the philosophy and the culture and the way people think and the underlying mindsets that lead to the use of these practices, or even the original development of these practices. It's not all about the tools. The tools and the technical methods are important, but we also, I think, have to build upon a foundation of culture and management system. So when you go to the Toyota plant here in San Antonio, and this is true at visitor centers and their plants in Japan and other places, you see big displays about what you might call Lean or the Toyota production system, or the way they label their management system as the Toyota way. Hits you right in the face when you first walk in. And you know this is from the Texas plant because you see these little Texas stars up in the corner. We love putting Texas stars on everything. Toyota has become a good part of our community here. But they emphasize two things: continuous improvement and respect for people. And now that phrase respect for people runs the risk of sounding trite. I'm like, yeah, we respect people. But it doesn't mean being nice or just kind of superficially treating people well. It means sometimes challenging people, but at the same time supporting them. So because we believe they can do better, we challenge them, we help them. Because we respect them, we also try to create the right environment and circumstances that allow them to succeed. We get continuous improvement by respecting and engaging people, and we're driven to continuously improve because we respect people. And these ideas very much go hand in hand. So when we talk about respect, it doesn't mean just the employee, it also means the patients. When we talk about patient-centered care, part of me says, well, I don't know, what else would healthcare be if it's not patient-centered? But the reality is we're often trying to help move the needle in a way that allows us to become more patient-centered. As Dr. Don Berwick, of course, the founder of the Institute for Healthcare Improvement and somebody I really respect and admire, has said before, lean thinking and true patient-centeredness are not just compatible, they are at heart the very same thing. So when we're driven to improve patient safety, improve people's outcomes, reduce waiting times, provide better service, this is all very patient-centered. And if there are problems in these areas, these are great things to focus on with Lean. Again, not just implementing tools, but solving problems and solving problems that matter. Well, let's go back and think about our staff. Take care of the staff so they can take care of the patients. We'd say, a lean culture, a lean management system, lean leaders respect and support staff in the mode of servant leaders, not in, kind of a patriarchal or matriarchal way. We respect and support people and we work together. We ensure people have what they need to do the work, that surgeons always have the right instruments that are properly sterilized before they try to start a procedure, that nurses aren't running around searching for IV poles and supplies and medications. We want to make the work easier for people so they can take better care of patients. Don't put people in a broken process. We can have great people in a broken process, or we can have great people in a great process. And that combination of great process with great people will allow us to do better. And it's less frustrating for the people working in healthcare. We want to be careful not to drive cost cutting through layoffs. This is a very important lean principle, to try to look for other ways to reduce waste and to save money. And avoid situations where we really demoralize people by relying on layoffs. There's a growing number of hospitals that have some variation of a no layoffs philosophy or a no layoffs due to lean approach. So we want to make sure people aren't overburdened and that we have the proper staffing levels. Sometimes that means we need to add staff when the demand and the workload really merits that. We want to match staffing to demand. If we don't need as many staff, we want to maybe let that number go down through attrition rather than layoffs. We want to give help and support when needed. Don't make people struggle on their own. We need to let them ask for help and be there to support them within a team or as a leader. We respect people by not blaming them for systemic errors. When something like 90% of problems are caused by the system, we don't want to react as a default and ask, well, who messed up? We want to ask, why did that problem occur? And we want to let people do meaningful work that allows them to work up to their level of licensure. Let nurses be nurses, for example, and listen and engage people in the improvement process. These are all very positive things. These are things that we should see taking place in a quote unquote lean journey or a lean transformation. We shouldn't be alienating or frustrating people. We should be making things better for staff and patients. Now, it's often said, and I hear this a lot in healthcare when people say, well, yeah, we need to improve. But, well, people hate change. And I like to challenge that. I mean, I think people hate being told what to do. And I think as the management professor, the late Peter Schultes said very succinctly, people don't resist change, they resist being changed. Stop and think about that for a minute. I think for one, there's that difference between being forced to change and being allowed to participate in identifying problems and fixing things. Then there's also the difference between a change, which might just be different, and an improvement that's actually better. We need to make sure we're driving improvement. So we see sometimes stories in the news where people are upset with lean. They're complaining, and maybe rightfully so, if something is really not an improvement, but just a change. So there was a big electronics company a couple of years ago that had an Office 5S initiative that was part of a lean office initiative. And people were told things like, you're not allowed to hang the sweater on the back of your chair in your cubicle. Like, it's dumbfounding how a sweater prevents somebody from doing a good job for the customer. Like, that seems trivial and not a problem that needs to be solved. It's probably not even a problem. There was a story in the British press going back a few years ago in one of their government tax offices where their lean office initiative, basically told people to put tape around everything on their desks. And you think, well, gosh, sometimes it's helpful to mark where items go, especially in shared workspaces. But I'm telling you, if you could see my desk here in my home office, I have not taped off where my computer goes because that computer never moves. It never gets lost. There's no problem to be solved by putting tape down. So look at this picture with the phone. The phone never disappears. Why would you mark? And why does it matter where the phone is on somebody's desk? So if we're doing things like this, and people are really upset, we should probably listen to their common sense and say, well, maybe they're upset because they're being forced to do something that doesn't make their own work easier or doesn't make things better for the customer. So one of the habits that we try to develop in a lean culture is to stop jumping to solutions and instead make sure we're framing things as problems and then work to find ways to solve those problems. So one solution that gets thrown around is as a best practice, and I know this is powerful. I'm not questioning the idea of hourly rounding and all of the evidence and experience that shows that rounding on patients at least once per hour reduces the number of times they press call lights. It means we can be more proactive with patient needs instead of having to run around reacting all day long. It reduces falls because patients aren't tempted to get up and try to go to the bathroom on their own and fall and hurt themselves because somebody couldn't respond to all of the different call lights that are going off. This is, I think, it's a perfectly fine solution. But it runs the risk that it seems too easy, or we say, well, yeah, we did some training on hourly rounding. So as leaders, we just assume that hourly rounding is taking place. We need to go and confirm to see if this is really true. So first off, I think it would be better to frame, if someone says, we want to do hourly rounding, I'm going to ask, what problem are we trying to solve? And there might be a number of problems. Focus on the patient. Well, length of stay is longer than it needs to be. Great problem to solve. Too many patients fall and get injured. Patient satisfaction scores are too low. Those are really compelling problem statements. And instead of running to the staff and saying, hey, everybody, we're going to implement hourly rounding, they might roll their eyes and say, oh, great, another program. But if we start off with a discussion around, hey, we want to improve the patient experience and reduce falls and help get patients home sooner than later, people are probably going to help rally around a problem like that. And then we work together to pilot and experiment and test changes and incrementally improve the way those things are being done. So one example, we talk about testing a countermeasure. If, let's say, there's a problem that says, hourly rounding isn't really taking place. So we're going to put up a check sheet outside of every patient room for nurses or techs to check off when they've done hourly rounding. So now leaders, whether it's a frontline manager or senior leaders, need to come out to the unit and look with their own eyes and say, well, don't just give me a monthly report on the percentage of hourly rounding that was done. I'm going to look and see. So this is an example. Saw at a hospital, and it was about 4:30 in the afternoon. And you see a check sheet like this, and it kind of jumps out at you that it looks like hourly rounding is either A, not always happening, or B, just isn't being documented. So we need to investigate and ask why and figure out what we can do about it, and not just pressure people to check the boxes. At this hospital, one of the patient care techs, she was really young, and I think she was new to the job. She, in all earnestness and sort of naivete, she volunteered. She says, "Well, what I do is I go around at the end of the day and I fill in all the check boxes." Which, again, that's not the purpose. The problem is not that the boxes weren't being checked. The problem is hourly rounding is not occurring, and the more important problem is, again, maybe that patients are falling and getting injured. So maybe better than these check sheets would be an example of a lean practice called visual management, where I've seen hospitals that will put up these sort of inexpensive timer clocks outside of each patient room. And when hourly rounding has been done, the person resets the clock. And you can see, in this case here, it's been 20 minutes since hourly rounding last occurred. If we see a clock that's all white, that means the time has run out, and we know it's been at least 60 minutes since hourly rounding occurred. I think the visual is a little bit backward. I would rather have the red indicate a problem. But either way, once you learn how the clock works, you can look down a hallway, and more easily than check sheets, you can see at a glance, oh, look, I see a little bit of red, but I see mostly white clocks. That tells me that right now, this instant, there's a problem with hourly rounding not taking place. We need to, again, as leaders, ask why. To partner with people and say, look, we're all working together to solve these important problems. It's not just about me forcing you to do hourly rounding. The purpose is to help and protect the patients. That's what we need to collaborate on as partners, as opposed to being adversarial. So we have this notion of Kaizen. Here's another picture from the Toyota Visitor Center that says, Kaizen is a relentless pursuit of perfection through innovation, which drives continuous improvement. It basically means good change when we translate the word from Japanese. And if we look at health systems, we have different types of Kaizen. We have really large changes like building a new tower, implementing a new EMR system. The size of the bubble represents the size of the problem. It's interesting that the EMR bubble is way bigger than building a building. We've got a small number of really big Kaizen good changes. Then there's that middle level where we might do rapid improvement events or Six Sigma projects. And then there's this layer at the bottom, all of the hundreds and thousands upon thousands of small improvements that can be implemented by frontline staff. So let's talk about some examples of good changes and results that we're seeing in healthcare. Theta Care, a health system in Wisconsin that's been practicing lean and developing a lean management system and transforming their culture for 12 or 13 years, they, over time, reduced the door to balloon time for patients with chest pain from 92 to 42 minutes. It wasn't just one big improvement or one instantaneous change. These times were brought down gradually and consistently over time, and they've been maintained in roughly that 40-minute range. That means better outcomes for patients, lower mortality, better recovery from heart attacks. A number of hospitals have increased nursing time at the bedside from 30 to 60%, not by asking people to work harder, but by eliminating waste and fixing the broken system that they work within. So instead of wasting time searching for supplies and equipment, they can now be at the bedside with the patient more often. That time at the bedside has great results and benefits, for example, reducing pressure ulcers by 80%. There's increasing number of reports, and I've been involved in some hospitals where we've reduced falls or pressure ulcers by roughly an 80% difference in a very short period of time by improving processes and fixing the system. There was another hospital I worked with years ago, a children's hospital, where little kids were waiting 12 to 14 weeks to get in for an outpatient MRI that was done under sedation, which is a very long time to wait. It was twice as long as the wait for the competing children's hospital in their metro area. By forming a team, by working on a 12-week project, we were able to reduce that waiting time to be just 2 to 3 weeks. And again, that came through improving processes, better synchronizing the scheduling process with the reality of MRI scans. Getting people involved in solving lots of little things, some bigger problems, led to that dramatic improvement. And we've seen at Franciscan St Francis Health, which is where my co-author Joe Schwartz works, they've improved patient satisfaction, family satisfaction in the NICU to the 99th percentile. And you ask them, well, how did Franciscan do that? They would say it was because of their Kaizen approach to continuous improvement and employee engagement. And that's what I'm going to talk about next. So Franciscan St. Francis, they are a 3-hospital system within the Indianapolis area. They have been practicing Kaizen-style continuous improvement for about 8 years. They started back in 2007, and they've had really great results. They've had, since then, 23,000 improvements since 2007, 23,000 different problems identified and solved by staff. Last year, in the last couple of years, they've had a 40% staff participation rate, meaning 40% of their staff have been involved in a small improvement, at least one. Now, I give them a lot of credit. They don't, as leaders, they don't blame the 60% who did not participate last year. And sometimes it's a different 40% participating every year, which is a different problem. Why did somebody participate once and then not participate again? But then you have some departments where the leadership is so engaged where basically 100% of their staff are participating in Kaizen on an ongoing basis. So they look and they say, well, what's the difference in leadership and culture between these different departments? What can we do to get more of that 60% to participate? So they aim higher, but they're still, I think, doing amazing work. 23,000 improvements, about 4,000 a year on average. They've documented more than $6 million in hard cost savings, and those are only the cost savings that finance is willing to sign off on. You know, finance, rightfully so, they're sticklers about not just claiming cost savings, but they estimate that there's at least a 3 to 4x multiplier between the hard cost savings and the other benefits that come from improving patient safety, quality, the patient experience, and the staff engagement levels. So some of that flows through to the bottom line. Some of that we know it's just the right thing to do, and collectively it has an enormous impact. So back in 2007, their very first Kaizen, and I share this as an example of a small staff-driven idea. Debbie in the housekeeping department identified a problem that coffee filters were getting contaminated and some had to be thrown away. So her improvement was just to do a small plastic container, a couple of bucks, or maybe they just had one laying around. And as it was documented here in a simple format, before and after, it says, okay, we have an improved environment, better cost savings, and we use fewer coffee filters. Now, the thing that I think is really important about this approach is that we don't insist on there being a hard ROI for every single improvement. Because what happens if we say no to Debbie's first idea because the ROI isn't positive? We'd say, well, she might stop participating. So when we allow people to implement small solutions to problems that they notice and matter to them, that gets the ball rolling. You build momentum, you build enthusiasm, you have more people participating. And that sometimes leads to ideas that do have a big cost impact. So what is this 5-step Kaizen process? We help people find ideas, we discuss them, we implement them or test them, and then we document and share what we've done. So the first important thing is to ask staff to identify problems and to come up with ideas. And as a leader, we work together with them. It's okay to go and ask people. They're not complaining. They're pointing out something that they want to make better. So we can do this through team huddles, through informal hallway conversations. If you see somebody who appears to be struggling with some aspect of their work, just to ask. And this needs to be done on an ongoing basis. Hospitals are, I think, sometimes fond of asking employees to wear buttons that say things like this: ask me if I've washed my hands. I don't know. I think the hospital needs to solve that problem rather than asking the patients to ask. But maybe the staff could walk around wearing buttons that say this: ask me if I have any ideas. Because I'll tell you, they do. Like, a lack of ideas is never the bottleneck in the improvement process. If we ask, why don't we have a culture of continuous improvement? It's not because people don't have ideas. It's more often that managers aren't asking, they're not looking for opportunities, they're not engaging people, and that's why it starts with leadership. So we might ask people to fill out a structured card, like this Kaizen card. It's not just a suggestion box slip that says, what's your suggestion? We follow that lean habit of saying, what's the problem? Do you have an idea? Write down the date and your name. What are the expected benefits? Who else do we need to work with? This really helps move the process along in a collaborative way. If somebody identifies a problem and doesn't have an idea, that's okay. Somebody else in the team might have an idea. If someone comes forward with an idea and hasn't written down the problem, we might ask them to go back and think about what is the problem that we're really solving. And then instead of jamming cards in a suggestion box, we can put them up on a bulletin board, or we can put them in web-based software that provides visibility and transparency way better than a suggestion box would. So here's a picture of a Kaizen board from a hospital lab, where you have on the left your new ideas, things they plan on doing, things they're currently doing, and things that are completed. And cards flow through from left to right. People can see what's going on. They don't worry that, oh, maybe my idea has been blown off and forgotten. It's transparent. People can collaborate within the team and with their leader. So let's look at some examples of cards from hospitals. Here's one that's pretty straightforward. Problem: patients are asking for ginger ale when they're nauseous, but it's not stocked in the first floor west unit. We have to go to the second or third unit. So the idea was a simple, basically, just do it. Let's stock ginger ale on our unit. So the expected benefits would be less running around and increased patient satisfaction. That was a change that was put in place immediately. There was no waiting for a suggestion box committee. If it's something that's a just do it or a just test it, we want to take quick action, because now this reinforces that Kaizen is a good process and this drives more participation. They also wrote down that said this: the problem is that 2 of the foam canisters were empty for hand hygiene. We're asking people to wash their hands. We need to make it easier for people to wash their hands. So the idea was to improve the process for quickly replacing an empty canister. Well, this is one that might require some investigation. It's not an obvious just do it. Who's responsible for replacing those containers? Or maybe we might ask to reframe the problem as, how do we make sure those canisters never go empty, rather than just trying to replace it really quickly? So this is one that you might need to talk through and brainstorm and come up with different things to try out. But the point is solving the problem of things that get in the way with proper hand hygiene in the name of protecting the patients. So we sometimes talk about barriers to improvement. And I would invite all of you to think about this in your organization. If there's not a culture of continuous improvement, or if you don't have as many people participating as you would like, to ask why. What are the barriers? And one of them that usually almost always comes up first is, we don't have time to improve. Well, maybe that's the first problem that we need to solve. Instead of letting lack of time be an excuse, we can work together to figure out, how do we free up time? If it's important, we'll make time for it. I sometimes ask people, well, say you don't have time for improvement. Maybe. Do you ever run out of gas because you didn't have time to stop and put gas in the car? Most people would say, well, no. Why? Well, even if I'm running behind, I stop and I make time to fill my car up with gas. So, I think we want to make sure that we're not hiding behind barriers or making excuses, but that we take steps to reduce or eliminate those barriers. If they're real, we need to solve that problem. One strategy for the lack of time barrier, or barriers around fear or things like that, would be to start with baby steps. Small improvements, small problems, that's less scary than big ideas. So we get people participating, and then we can increase alignment. We can start asking for certain types of ideas, but we generally want to start off by asking people to fix what bugs them, and to fix things that we can fix, rather than throwing everything to maintenance or pointing fingers at other departments. We want to start small, and then eventually we can get big with our ideas and our results. One other way we build enthusiasm in a Kaizen process is to take the time to document and celebrate and share our Kaizen improvements. We give recognition within a team. This is something a client of mine years ago dubbed the Wall of Fame. These Kaizens, they sort of mislabeled them as Kaizen events. It's really small Kaizens, not formal week-long Kaizen event projects. Hundreds of Kaizens that were implemented by staff to thank them, to celebrate them, and to help spread and share these ideas throughout different parts of the laboratory and throughout the hospital is critically important. And that makes people feel good, and they do more Kaizen. So again, this process is pretty straightforward: to find opportunities for improvement, discuss them, implement them, document them, and share them. Because then what you end up with is something that really is a striking lean culture, or a culture of continuous improvement. And I invite you, come to my blog and look at these videos from Franciscan St Francis. In one of the videos, two nurses you see here from the endoscopy unit, they said this: the culture here is staff input into everything. Now, that doesn't mean everybody gets to do whatever they want. It means we get staff input, and leaders are working with them in a collaborative way, and we're not forcing change on people. They want staff figuring out how to fix things. They ask, what can we do to make our job easier? And the managers, allow us to implement things to see if it will work. And I think that's really key. We engage people, we work with them. That fixes the problems that matter, and it develops people. So as Toyota teaches, Jamie Benini, who works with Toyota suppliers and nonprofit organizations to help create a culture of continuous improvement, points out that the role of the manager is, I would say, not to fix everything yourself, but to develop people, create an environment where they can surface problems and solve problems, create an environment where this happens, and continue from there. When we focus on our people, the people we serve, the people who are serving them, when we protect them, when we support them, when we manage them and engage them in a new way, That's really what Lean is all about. And you develop this incredibly powerful force in your organization where people don't want to leave because they can't imagine working someplace else, and that they are driving improvement in a way that no other organization can copy, at least not easily and not quickly. So this is, I think, the great opportunity to create a real sustainable competitive advantage. Now, I would love to see every hospital have this culture, but those that have a head start on others have a huge advantage in the healthcare landscape. So with that, I want to thank you and Kronos and Becker's for having me here today. Here's my contact information, and it'll be available. I invite you to reach out. And we're going to do some Q&A here, but first we're going to turn things over to Greg.
All right, thanks, Mark. That was fantastic. I love the process and all the really practical examples. Sometimes that sparks the idea to get to the next step, so thank you for that. Now, when I was thinking about my part of the presentation, I asked Mark if I could take a peek at his slides, and one of the things that struck me was this slide at the upper left, which you remember he walked through each of the line items, and I won't go through those again. But what struck me was a lot of these, the ones I circled, are directly impacted by how effective we're scheduling our staff. And as you can see, the lower right image here, the challenge for all of us when we're scheduling and staffing is aligning our actual staff with the demand that we see, right? And it's very simplified here about actual labor and ideal labor, but we know if we overstaff, we run a cost risk, and if we understaff, we run a quality risk, or we have a throughput issue. And so the issue is, how do we bring those two lines together? And this is an area that is a little more challenging as soon as you've lived it for a while, because one of the first things right out of the gate is just even understanding the ideal labor to support the demand you see is really difficult. And there's a bunch of other issues that cause the actual labor that you're staffing to vary as well. And I've listed a number of those causes of what I call misalignment down the left. So things like I'm estimating my demand by my budget. I may have an annual budget, and I'm breaking that up into 52-week periods and using my experience or other information to take some from one week and add to another week. There's also last-minute changes, right? An accident occurs, or we're getting diverts from another hospital that we weren't expecting. You have planned and unplanned leave that changes your availability, your capacity to staff. And you have unexpected things like sitters. All of a sudden, you have a person you were expecting to handle a certain number of patients is now sitting with one, providing that patient-centered care that we all want to do. And then finally, if you try and stretch people the other way, you have cost pressures, and you're overworking people, you're going to get lower productivity, fatigue, accidents, and low morale in general. So these are all the things that are causing misalignment, and over time we've figured out techniques to flex our staff to react to that, right? We have things that we do in the moment to react, and then we have longer term things in terms of increasing your capacity or reducing our capacity. But what happens is this becomes harder and harder to manage. And Mark talked about not using tools as your primary motivator to identify a problem, and I've heard him say creativity over capital, right? Think about a good idea that you can do just within your own process without investing in something that might be overkill, and I absolutely agree with that. One of the things that we're seeing, though, is sometimes tools are necessary, and in the staffing world, the workforce management world that I live in, things are changing that are just driving this to become more and more of a necessary tool. And those are things like increasing volumes of data are making it harder to observe a process. One of the techniques is go to the Gemba, see the process in action. Well, as our spans of control grow and we're overseeing people in multiple buildings and multiple departments, it's almost impossible to get to see and observe all these processes. So you have to become dependent on the data to make your decisions. As we saw all the different types of misalignment and flexing techniques, you are also constrained by regulatory requirements. And it becomes a complex choice to even move somebody from one department to another and ensure that you're balancing quality of care with cost constraints. We also have some opportunities, right? It's not all just getting harder. We also have some opportunities that data, such as that huge bubble, once it's done, we've got some great data that we can reuse. We've made a huge investment to capture this data. Let's see where else we can reuse it. So you can start to use things like data from ER to create census-based demand and start to improve that budgetary driver into a budgetary plus a census-based demand to create your schedules. And then finally, we're just beginning to see, it's especially in the workforce management area, that we can apply big data techniques, right? A lot of hype about that, but it does boil down to some practical applications that we can reuse that data again and find even more subtle patterns and trends and outliers and best practices that we can share with the rest of our organization. Now, I'm not going to subject you to a demo of some of the tools that I'm talking about, but I thought I'd put a couple screenshots and just show you an example of what these things actually look like. It sometimes helps to actually see rather than just talk about these things. But on the left is a monitoring tool, a dashboard that allows managers to become more agile, right? They can see things immediately wherever it's happening and be alerted to things that they have to react to. When we talk about an overall system view, not optimizing something locally, visualization techniques and tools really help you to take a look at an overall picture and lots of data and shrink that down to something that's manageable so you can identify something that's wrong in the overall system. And then finally on the right is an application of big data where we're clustering information about employees and identifying behaviors, both good and bad, that can either be shared or need to be corrected. Things that we were never able to identify before, like my supervisor is playing favorites, and I'm really getting disengaged, right? How do you find that out? How do you prove that? Well, with big data techniques, you can take those soft problems and apply hard data to it and really come to fact-based decisions, right? It's a whole new world that's just opening up to us. So, again, as you get into these tools, there is going to be ROI required, right? This isn't putting a plastic bucket around coffee filters. But that being said, the benefits are also significant, and that's why companies invest in these. And I have two testimonials here. I'm just going to quickly go over them just to highlight so you're aware they're out there, but you can certainly see the full videos at Kronos.com. But the first is Allina Health, where they were challenged with balancing, of course, cost and patient care. And what had happened is there were some real constraints against hiring. But what had happened is their business was growing. They were starting to use the flexing techniques that we saw, but scared to hire people, right? Discouraged from hiring people. They were starting to use travelers and overtime employed, I should say, workers to come in and increase that capacity. But what they found was that because they had distributed scheduling methods, that everybody was not making the best choices. And what had happened is their costs were increasing much faster than their capacity could support. And they had to address this. So what they did was they centralized their scheduling, a lot of their scheduling processes. It gave them much better visibility to what was going on, and they could justify. And what they found out is they needed more full-time employees. That was the best outcome for them in terms of cost and quality and employee satisfaction. And they were able to make those justifications, but just in the places where they really needed them over the long time, so they weren't in this cycle of hiring and then laying off, as Mark said, is extremely discouraging. So what they realized out of that was not only were they able to cut their costs, but because of these gains in productivity and being able to apply the right people in the right places, they were able to accept more patients in their ED, for example. Before they started this, they were diverting patients away because they just couldn't handle the volume. Now, the last 2 years, they've increased their ED volume by over 7% each year. And so not only are they saving money, but through this process, as Mark suggests, overall outcomes are there, right? They're increasing their revenue and saving costs. It's a double win. And so a really exciting story. Another case is at Robert Wood Johnson. Their challenge was that they were flexing staff, as we talked about again, and they were not necessarily using the best techniques, right? And that happens. It's easy just to shoot out some overtime because it's immediate. You get trained people. The employees often like overtime if it's not being used too frequently. and their costs were rising more rapidly than, again, their revenues could support. As a result, again, because they didn't have the data, they were saying, okay, we need to back off, we need across-the-board cuts, which is really demoralizing if you're one of those managers who's been really watching your staff and your costs, and suddenly you even have to cut more, but you look across and you see somebody else who's not taking that much care, and they have the buffer that they can cut without impacting their business. So this data also allowed them to really carve out where they had excess, and where people were doing a good job, they could leave them alone. So as a result of their efforts, and this is a really great story that Desiree recorded for us in last November. They just started this a year ago. They had planned on about $3.5 million worth of savings. That was their promise to their management to invest in this analytics tool. What they found was that by November, they'd already saved $7 million, right? So really excited about that, and they think that they could potentially hit $9 million. And I haven't checked in with Desiree since then to see what happened at the end of the year, but they were on target to save $9 million. So when appropriate, a tool is a good thing, and it can really deliver significant results and solve those kinds of problems we want in terms of respecting, supporting our people, and increasing revenues and patient care. So with that, thank you for attending. Mark, thanks again. And Emma, I'll turn it back over to you for any questions that we might answer.
Great. Thank you so much, Mark and Greg, for a very informative and enjoyable presentation. We will now begin the question and answer portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time, and we'll follow up on questions that they don't have the opportunity to address. So the first question here is for Greg. And Greg, an audience member is curious if you could explain what is meant by big data techniques. The term big data seems to be used a lot, so they're curious to know what exactly it is.
Exactly. That's a great question, right? I don't even know if I can define big data. I haven't found anybody that's given me a great definition. But in this case, what we consider big data is two things. One is, most people won't know this statistic, but I'll share it. For every 1,000 employees, you have about 1 million kind of transactions that occur in terms of punches and schedule edits and time card edits, 1 million transactions per year. So if you think about a 10,000 employee hospital, you have 10 million records to analyze. What big data techniques or these statistical techniques do, and in the case that I'm talking about, we use k-means clustering, we can identify groups of behaviors that are occurring over a long period of time and pull those out of that 10 million records and identify either supervisors maybe doing things that we don't want them to do, or in the reverse, identifying supervisors who are outperforming others, and we want to investigate and find out how we can replicate that. But what we found is big data is, and we've done this on a number of customers, is that the typical controls of automation or metrics or supervisor feedback are not picking up on these behaviors. But big data techniques are able to identify these, and then we can follow up on them. So that's my interpretation of big data for workforce management.
Great. Thank you so much for that clarification. Mark, the next question is for you. We have an audience member who's interested in the best way for a leader to get started in Lean and then roll out in their organization.
That's a great question. I mean, I think one way of answering that would be to think about this idea of trying to do some sort of rollout over time. I think whether an organization is embracing continuous improvement practices like Kaizen, or if they have broader Lean management system and culture elements that they're trying to embrace, is to not try to do this as a big bang organization-wide approach. This is not like installing a piece of software that you install and just give everyone some training on and all get up and running right away. This is something that's very time intensive. It requires coaching. If you try to, let's say, start a Kaizen process too broadly, too quickly, a lot of those departments are going to struggle and fail without coaching from the process improvement department or knowledgeable senior leaders or an outside person like myself. So my advice always is to start small get some wins, demonstrate that Kaizen works in the organization, learn how to solve and eliminate some of these barriers, and then take those lessons and spread things from there. And then, those earliest managers in those first pilot departments become people who can then coach and mentor their peers in other areas. So I always encourage people to start small, have some success, and then expand practices from there.
Great. Thank you so much for that advice. Mark, the next question is also for you as well. When employees submit problems through the process that Kaizen has achieved, is that employee recognized and rewarded? And what are some examples to recognize participants?
Yeah, so that recognition piece is incredibly important because that builds upon the intrinsic motivation that people have to make their workplace easier and better and to improve patient care. So recognition can happen in a number of ways. It could be a handshake or a fist bump from the employee from the manager on a one-on-one basis. It could be recognition at team huddles. Let's celebrate the 3 Kaizens that were implemented and documented this week. Different organizations have different approaches where certain improvements can get recognition from senior leadership, shared more publicly throughout the hospital in newsletters or bulletin boards or different ways. My co-author's hospital has an annual awards ceremony. It's kind of like the Academy Awards for Kaizen. I think a good best practice is to focus on the recognition side of rewards and recognition. A lot of times people put too much focus on the rewards. They create a big bureaucracy that's not necessary. And one thing I think is to especially stay away from is the old suggestion box approach of promising people a percentage of cost savings. That sounds good, but then when you actually live through that, you see how it gets dysfunctional of people fighting over the amounts of the rewards, and it can get in the way of teamwork. And, I think we don't want to replace intrinsic motivation with extrinsic motivation. I highly recommend the book by Daniel Pink called Drive, or go find a TED Talk or a YouTube video by him. We want to maintain intrinsic motivation. And I've seen reward systems work when the rewards are relatively small, a couple of dollars, points towards gift certificates, small and relatively even keel, and given to everybody who participated in a Kaizen improvement. Suggestion boxes tend to reward one person when improvement usually is a team activity. So we want to eliminate those sources of conflict and dysfunction and really focus more on the recognition piece, not necessarily the rewards.
Great. And it looks like we'll have time for one more question. And Greg, this question is for you. We have an audience member that sees how a good schedule supports the tenets of respect and support of people. Scheduling is a complicated process for them. So how would you suggest improving it and getting started?
So that's a very common situation. And the first thing is it's very few, and let's just say no companies that fully automate this scheduling process, right? The idea is just to relieve the scheduler, the person doing the scheduler, of the things that can be automated or are very predictable, or give them a smaller set of decisions to make that have been optimized. So one of the first basic practices for scheduling is just making sure that everybody's time is entered and their planned time off has been entered, so that you can see what your starting place is. Is it easy to get to their availability and their preferred shifts? If you can just get that first sense, you're not conflicting with what the employee has planned and causing heartache for both the employee and yourself and disruptions for the schedule. So just using basic time and attendance and leave and request for time off processes and getting those tied into a schedule is a great first start.
Wonderful. Well, thank you so much to our presenters and Kronos for their excellent presentation, and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.